Good afternoon, all of you. This is Dr. Megha Agrawal from Healthcare Sector Skill Council. Welcome all of you in the 20th edition of Healthcare Insight Series, the initiative of Healthcare Sector Skill Council to collaborate with the industry leaders and experts and bring out very important niche topics every month to you for your awareness, for your skilling, for your upskilling, for the updation of your new technologies and other activities. So today, again, we have brought Dr. Rohini Paul, the Dean Academics from Esther DM Healthcare. Thank you so much, ma'am, for taking out your precious time and joining in. Dr. Rohini Paul is an esteemed nursing faculty. She is PhD nursing and having experience of more than 45 years, established so many centers, cardiac centers, many hospitals, and with her immense experience and expertise, I'm very grateful that she is taking our very niche topic, the tracheostomy care, which is very, very important skill, very and that is something a skill which can save our lives if that could be done in a perfect manner. Thank you so much, ma'am. Today, ma'am is not only going to take up the topic, she is also going to demonstrate this important skill to all of you. I hope all of you would take a good insights from ma'am and learn new skill. Uh, I request all of you to keep yourself mute and whatever questions if you would be having, keep posting on the chat box. We will take after the demo and ma'am's topic would be completed. Then we will take all your questions one by one. Over to you, ma'am. Thank you so much for joining in.
Thank you very much. Thank you very much. Very encouraging. We'll start or wait?
Ma'am, we can start.
Okay. Actually, I want to thank HSSC and all of you for this wonderful initiative once again. Again, the chance given to us. So thank you very much, Dr. Megha.
Thank you so much, ma'am. So floor is yours. You can start your sessions, ma'am. Thank you.
So good afternoon, all of you. I'm sure many of you have joined from Aster different hospitals and especially our academy CMI. And see, I'll just show you few things, a few slides about an introductory thing as a theory part. Then we'll go for the live demonstration. So it's all about tracheostomy. So when you talk about tracheostomy, all of us nurses, the very important thing, we should know a little bit about the anatomy. See, if you don't know the anatomy, you have no idea where this tube is going in. That is my desire to show you this. So when we talk about nothing, just few things. So you should know where is the larynx. So I have given a picture here. I'm sure all of you can see that. So one is that number one is larynx, very important. The next one is thyroid cartilage, because this is also the tracheostomy tube is part and parcel of it. Definitely you should know it is inserted just the same in trachea. At least that much you all should know, it is inserted. And tracheostomy tube is the one. So here it's shown tracheostomy tube. And the next level is thyroid gland. That is also very important because at the time of performing the tracheostomy, so all of you should know, trachea is that windpipe. Ostomy is making an opening. So tracheostomy is making an opening in the trachea and passing a tube, which we will explain. So when the procedure is done, say I have kept a set, I can just show you how many instruments you will need to make tracheostomy, to make this procedure. So that is one. So I'm just giving you small introduction on the anatomic part. So as you all know, as I have told you, tracheostomy is just an opening which is made into the trachea. See, the reason is if the body is created, so I'm not going detail on that. The nose is on top, mouth is behind down. But there is a reason in somewhere in the throat it has been switched over. The windpipe comes forward, the foot pipe goes backward. The reason behind the way it is created that way, the trachea, the cartilage, it's made up of cartilage, it will not collapse. It's a corrugated tube, you can touch and see. So it is come forward, that's why we get aspiration, all the complication. So making an opening, even 2000 years back, 1000 years back, if there is some edema in the head where the air cannot go through the nose to the lung, they made a small sharp stone, they made a hole in the trachea, and through that the air went and the human being was living. So this has happened many years back also, when there is no surgical procedures were performed. So they understood this is a windpipe. So that is what I'm making a hole in the trachea and putting this tube. Now there's a lot of advancement. Same thing as all the ICU nurses who are joined. For 7 days, the same tube will be put through your nose or mouth. That is about the intubation. Maybe the thing is connected with the ventilator. You must be seeing on the 7th, 8th day, there will be a tracheostomy done. The same endotracheal tube will be passed through that. The reason is, above that tracheostomy area, there can be edematous, swelling will happen. That is not acceptable. That is why after that, they make a hole and the same endotracheal tube will be put through that, so that will be taken, because it's directly going into the trachea. So that is what it is. So I'll show you the little bit part of the tracheostomy tube. And as you all know, the purpose, as I have already mentioned, definitely to maintain the air patency. If there is an edema, there is a head injury, there is a fall, swelling in the face, where air is not going through the windpipe to the lung. So that is what to make an air patency. Again, this is what I said, prevent infection at the tracheostomy site. So this is what it is. When there is a long-term ventilation is needed, endotracheal has to be inside. Our ICU nurses know very well why, the reason there is a tracheostomy done the same tube. So that is also one of the things. Then there are some, so this is also the purpose is to facilitate the healing and prevent the skin exhaustion. That is one aspect. So one more thing, to promote comfort. So there are many other surgeries done in the face. So again, the tracheostomy is very much helpful. So that is one more thing. So what is the one more thing? What we are learning is to bring comfort to the patient and assess the condition of the ostomy. Ostomy is just the opening and the surrounding is called the ostomy. So that is all the purpose why we are making it. So indication, why do we do it? I have told you already, obstruction of the mouth and throat, definitely you have to make a tracheostomy because there's a swelling inside. Breathing difficulty caused by edema injury, there's a fall and the full head is swollen, air is not going in, definitely you need to do. So any airway reconstruction following by a tracheal surgery, you have to do the tracheostomy, because that time the air will not, again there will be sore, swelling, induration, all that will be there. So again, you need to have some kind of protection from secretion or food because of the swelling. Swelling is the problem. Swelling is the problem where the air cannot go in. Then again, anywhere above the surgery, CA buccal mucosa, definitely patient, the same entire buccal mucosa, that is cheek, and also the mandible bone is removed. All that reason there should be a tracheostomy. Some of them live lifelong with a tracheostomy. So there is always a long-term ventilation support. So as all of us healthcare workers, we should know why, at least 2-3 reasons you should know why a tracheostomy is done. That is all about the indication. So equipment needed, I will show you when I am going to do the live thing. So we definitely care, we need a kit because this is a continuous care. So sometimes it can be a temporary care where it is only done in the hospital and then no more. But there are reasons, like as I told you, the cheekbone, the buccal mucosa surgery, so many reconstruction surgery in the face done. So all that, it's a long term. Even if we teach the patient how to take care of their own tracheostomy, that's a different thing. So all this. So there is a gallipot. Of course, you all know what is gallipot. So I'll show you. Sterile towel we need just to put over the patient and so that it will not wet. And it is fully not sterile, but certain level it is a sterile procedure. And you need to have a brush, nylon brush, which this is one of the brush. Are you able to see this when I show? Can somebody respond? Can somebody?
Yes,
Okay.
ma'am. We can
Okay,
see.
thank you. So this is definitely this brush is very much needed, because when we take the inner tube, you need to clean it. So this is very helpful. So that is what one more thing. And then nylon brush. Then you should have sterile gauze. You should have sterile gauze. Please make it a point. You cannot contaminate. It should be a sterile gauze. How when to use it, I'll show you. Of course, cotton tie. We have a cotton tie, which of course you will be able to. So which again I will show you. The cotton tie is very important. How to tie? See, please, I want all of you to be with me. So when you have an opportunity to take care, so this is a cotton tie. No cotton ball will be used. Please make it very clear, because cotton ball, the small thread can go into the trachea. It can create disaster. Please, as healthcare industry workers, healthcare workers, you should make it only a gauze. Of course, this is a very perfectly made, we can call it a ribbon or a tie, whatever it is. So continue with the articles. So this is what, again, we definitely need to have hydrogen peroxide. Hydrogen peroxide, and we should have saline. So why do we use a hydrogen? Please, I want you to understand. Hydrogen peroxide, it has hydrogen peroxide, both hydrogen and oxygen. So whenever there is a depth, you are not able to reach. So that area, you put this hydrogen peroxide. Of course, here we put a very diluted hydrogen peroxide because it is included trachea. So the oxygen in the hydrogen peroxide will go and mix with the dirt. It will make froth. So that froth will bring the dirt outside. That is why always, even in deep wound, the infected wound, you pour hydrogen. So please understand, the oxygen will go and touch the dirt, the infected area, and make oxidization, may create a froth, and it comes out. Then of course you need to have a normal saline to clear the place. That's very important. We should not leave it that way. We need to have a sterile gloves. Please make it a point, sterile gloves. And one more thing, PPE, see, I'm already wearing an apron. This is to protect yourself, because all these things, which is some of the things with the body fluid, we talk so much about it. So this is going to be straight away from the trachea. See, when you're doing a tracheostomy, anytime there is an irritation, your patient will cough. So jerked out, lot of materials through the tracheostomy tube will come out, and it can come straight to your face. That is why I would recommend, because I'm taking class, I'm not wearing, it's better you wear an eye shield, at least a goggle. Please don't try attempting anything without these two, because anytime unexpectedly, because you might have small movements of the tube, so patient throat can get irritated and he can cough, and immediately the sputum will come on your face. So that is what I'm always telling you, should wear a mask, of course, inside, then your shield or your goggle. Then you should have always a waterproof pad, which is always on the patient, so that your patient, because you are dealing with hydrogen peroxide and saline, so many things. So this should not be wet. So we always make. So these are all the articles. So every time, so this is part of the tracheostomy tube. So as we healthcare providers, you should know the importance of all this. So there are few tubes. There is an inner tube and outer tube. So many of us, after many years also, we have not much knowledge. So we have a introducer. This is not very much. So this is an introducer which is there, which will be removed when the patient is supposed started breathing. Then this is an outer tube, which I have shown here. This is an anchor where it can hold. So always there is a thread. Of course, once it is done, there is a suturing done with 2-0 muscle, which is anchored to the skin immediately after tracheostomy. Of course, that is to the outer tube. So this is an inner tube. Please remember, this is an outer tube. We have a cuffed tube. Mostly a cuffed tube is used. Then there are uncuffed tubes also. So I'm sure all of you know the difference between cuffed tube and uncuffed tube. So cuffed tube is always
So that is inflating. So when we
deflate. So this is only to inflate. So it is anchoring the tube in the trachea. So this is just like the endotracheal. When you inflate, it stays. So that is the mechanism here. Same similar mechanism, like same thing. So one thing all of you should understand, again, here only the air will. Is anybody's mic is on? You have to mute. Please mute your mic. So there is an inner tube. So it is, if it is there, inner tube, it will be very good. So that every time we are going to talk about this cleaning only. So there is an inner tube. So as we all should know, we should never try to remove the outer tube. We should not, because only a surgeon or a clinician will remove. Because you will be displacing, suddenly the patient can go into choking, and it is going to be very life-threatening. So please understand, this tube will never be removed by us. So only thing we are authorized to remove the inner tube and then take it out, and then how to take care of this only I will be showing. So there is a difference between the outer tube and inner tube. Then here I have shown one, there is a plug. So that is also whenever there is a, so sometimes you don't put an inner tube, so there is a plug which can, because any insects, all that it can prevent, that is also will have a hole. That is what it is. So this is what is all about our tracheostomy tube. I hope if you have any questions, please ask me. I will try to explain. So there is some more things I will tell you. So a few things I'll talk to you about the responsibility, the healthcare providers. So every 8th hour we should do the tracheostomy care. So disposable, I told you, then replace them. So you want to take the inner tube and then you will have to clean it, and then you will have to replace it. So if only a single lumen is present, only you need to clean the, that's all, tracheostomy tube and leave it, nothing more. But please understand this. So hand washing is very important, because whenever it's going to be a long-term procedure, patient is having to have the tube for a longer time. We can never give infection to our patient. So that is what the hand hygiene is very important. So you'll have to follow the protocol, how it should be removed, with what it should be soaked, how it should be cleaned, how it will be dried, and how it will be inserted. That is very important. So that is what and one more thing is, how do you clean the stoma? You know what is stoma? That is the hole which is made, the tube is put in, that is called always the stoma. So how do you take care of the stoma? And how do you assess the infection? Every time you have to make sure their stoma is normal. There's no infection, no induration, no redness. So that is very important. So here few more I have added. So very important. See, there is a reason why we are doing. So all of us should know one thing. We know we keep on doing things, but we have no idea why I am doing. So that's what I made it. So again, assess the condition of the stoma. I told the opening of the trachea is stoma. So redness, swelling, any secretion, normal and abnormal, you should know the difference. That is what it is. You need to indicate, or If there is anything, you'll inform the clinician, and culture could be taken, all that. So then subcutaneous emphysema. So there is always a collection of small fluid or even air. That's what the next point is. So this is what it is. You should be very careful when you do the assessment. So avoid patient to a fowler's position. You know, fowler's position is reclining position. So when you patient wants to put 2 more, 3 more pillow, I want to sleep like this, you should avoid. Please, that is what it is. Patient to assist the patient to a fowler's position and place waterproof, but that is very important. See, you should not put in such a way your tube is going to bend like this. So please, according to the need, how the patient is comfortable, depending on that, your fowler's position should be placed. So that's very important. How do we do? You can't just keep on raising your bed and putting on 90 degree and all that. So go along with the patient's comfort. That's very important. And of course, wash hand, I told you, very important. Then this is what assemble the equipment which I have told you, which I will be showing you how it should be done. So hydrogen peroxide and normal saline, both are very much needed. So that hydrogen peroxide could be a bit diluted because of the medication it will be giving to the trachea. So as I told you, put on the mask, eye shield, which are very important. So this I will show you how it should be done. So I don't need to show here. So the heading side.
Excuse me, ma'am. Ma'am, your voice is not audible, ma'am.
No, it is audible. It's audible. It must be problem at your end, ma'am. Dr. Rohini, ma'am, your voice is audible.
Okay, I'll continue. Okay. So one more thing, see, remove the soiled gauze where you will place it. See, this is also, I'm telling, long term when you teach your patient, the relatives, this is our responsibility. So where the soil will be put, it should be detailed. There is no confusion. Then only the long term it can be done. As I told you, even the gauze will not be cut. Please make it very clear. No cotton will be used in tracheostomy care. Please mute your mic, you know. Mute everywhere. And no gauze will be cut. You can just fold it in a V shape and put it. But again, I'm telling you, if you start cutting the gauze, the small thread can come. It can go into your tracheostomy tube. So this is also very dangerous. So we need to be very conscious. This knowledge should be in your mind all the time. Then clean the stoma, which I will show you how it should be done. And of course, the inner tube cannula, how it should be removed, cleaned, I will show you. Then how do we replace? So replacing, putting back the inner tube is also very important, because totally the whole procedure when you do, because it should not irritate your patient and the cough should not come. So that is very important. So then how do we apply? How do you tie the tag? Everything is in detail. So I'll show you when I show that. So of course you will be doing your documentation, which dressing, how long it should be done. As I told you, make it very clear that it should be done every 8th hourly. So this is very important. So anyway, now we'll go to the demonstration.
हिंदी में बोलिए मैम.
Hello? Anything? Anybody has somebody wants to say something?
Somebody was telling you to talk in Hindi, ma'am.
हिंदी में बात करना. पूरा हिंदी में बात करेगा तो दूसरा कोई अंडरस्टैंड कर नहीं सकता है ना. You ask me, थोड़ा क्वेश्चन पूछेगा तो मैं वापस देंगे. ठीक है? Yeah. ಇದು ಬರ್ತದೆ ಸುಮ್ನೆ ಅಲ್ಲಿಂದ ಬರ್ತದೆ. ಇಲ್ಲ ಇದು ಪೂರ್ತಿ ಬರ್ಬೇಕು. ಈ light on ಮಾಡು. Okay. Just hold it. Okay, now I'll show you the articles as I have already showed you. So you need to have a sterile gloves. You should have a sterile gloves. Before that, I have a sterile gloves here. I have shown you the rest of the things. So you have a kidney tray because it should be bigger enough so that I'll put the hydrogen peroxide, and I have the saline here, which I will make the hydrogen peroxide, then saline. I have a galley pot, both in separate. There is a hand towel. I have a sterile gauze here. So this is all. Now I'll show you the tracheostomy. So there is already an inner tube. There is a tag here. So this is the inflated port, which is here. So this is what about. So our patient is conscious. So my patient's name is Anne. So whatever I'm going to do, because it's a very sensitive procedure. So I have to ask Miss Anne, as you know regularly, now this is the 8th hour. I am going to give you a small tracheostomy care, which I'm sure Anne, which is going to help you. Okay, go ahead. So Miss Anne has given me permission. She understands, she knows every detail of it. She's been in tracheostomy for almost 2 weeks now. So that's a good thing. So we can go ahead and do. So I have done my hand wash, and then I'm wearing my gloves. So now I have the saline here, and I have the hydrogen peroxide. So now I have kept everything. So there is a sterile towel which is already placed. So now I have already explained to my patient. So now here I have to assess the stoma. So this is the stoma. This is the stoma. I'm sure you all can see that. That's the opening which is done that through tracheostomy. So the outer tube is placed so that I can. So the outer tube is placed through that into the trachea. So this is what it is. It is sitting here. So now I have a small 2 areas where there is an already a suture done, but still this is an extra additional thing where I will be keeping this thing. So this is what it is. So I have to look for edema, induration, any collection of fluid here, or any collection of subcutaneous air sitting here, and the comfort, because once there is swelling, it is very dangerous. It has to be in the initial state, it should be taken care. So this is what it is. So now I have kept everything. Yes, anybody has any question? So all of you should know one more thing. That is what I showed you, the anatomy. The tracheostomy tube, you have a doubt. So as you all know, the trachea goes right here. So the tracheostomy tube, like if you put in the mouth along the tongue, it is going like this. The same position, your tracheostomy tube also will be placed. It is not a straight tube, it is a curve, you all know. So it goes along the trachea and it is seated here. That is what I want to explain once again. So now I have kept everything ready here. So now we have a suction ready, suction apparatus, which is kept ready there. So I have suction catheter connected here. So suction catheter will be kept ready because if there is a need, I have a sterile catheter here. So there is a sterile catheter which is already connected here. So this is what it should be, because anytime the patient can choke, because secretion can go undisturbed. So this is kept ready here. So now I am going to remove the inner tube. See, please, I'm making it very, say I'm removing the, so small, it is not fixed with things. So it has a handle. I just hope you all can see. I remove this. So I don't remove like this because that's why I showed you the outer tube. You have, as you remove it, it has to go towards like this and then you take it out. Please, this is what we make a mistake. You should not, so that is again, it's going to irritate your patient. So it has to come as in the direction when you take, it has to come like this and then remove it. You put in the kidney tray, don't put in a small thing. Then of course you hydrogen peroxide. So as I told you, we need a brush to clean. Please always remember you need to use a sterile, preferably a sterile brush. So that will take all the secretion from the inner tube, because there can be secretion always sitting. See, this is the advantage of having an outer tube and inner tube. So only when it is an outer tube, it's very difficult. So when you have an inner tube, you can always put like this and put like this. Don't force too much. So it is there. Now you can soak it in the hydrogen peroxide. Then of course you have another kidney bowl with a sterile saline. So please make sure after cleaning with hydrogen peroxide, it has to be cleaned with saline. Otherwise, again, it is, you know, hydrogen peroxide is an irritant agent. So it has to be cleaned with saline. Then, of course, you bring it. So inserting the inner tube, the same direction. You start from here, slowly you make it and you fix the inner tube. So this is one aspect. So before that, as I told you, see, first you don't start cleaning and all that. You finish this part first. This is the most clean place. Then you will go to the outer area. So of course, there are gauze which is sitting there, which you can remove it initially. We can put it there and then you can go for your cleaning. So now you will go for your cleaning. Preferably you use only saline for cleaning. So this is what it is. So now earlier I have assessed the wound. So now you will be doing the cleaning. So cleaning again, when you do cleaning, you should not move because it is irritating the throat. So this, wherever there is a need, you will have to just clean with saline. So this is what it is, your cleaning should be done. So once the cleaning is done, definitely your tag has to be removed. So this is very important. Please don't try to remove the tag before, because once you start doing the suctioning if needed or removing the inner tube, your patient will be get irritated and the patient can cough, your tube can be, outer tube can be displaced. So that's very important. So here I will teach you one important thing. Never remove both the end. This is very, very important. You should never remove both. As healthcare providers, you should understand tracheostomy one, because it gets dirty. So first you remove one, then remove the back, then take this off and replace with another new one. Then you remove the next one. If you remove this and if you remove this for some reason, if your patient is going to be having cough or anything, you will end up with a bigger problem of displacement of your outer tube. So always remember, it's better you measure and keep the tag first itself, measuring the neck of your patient and the tie from here. So first remove one, then you bring your new one connected here, then you go for your other one. So this is very important. So this is one important thing I want to teach you. So first you remove the one, the clean one, then you, of course you do it, then you remove this and then you have to take it. And only when you take a measurement, don't ever make a mistake of making it very small, or it should not be tight. It should be, at least your 2 fingers should go in between this, so that you will be able to have this patient, it will not be over the neck tightly. So this is what your inner tube. So now you have done it, you have examined your wound, you have cleaned it. Now your inner tube is been removed and it will be replaced. So make sure there is no, if there is a need, you will do suctioning, otherwise it is not needed. So once it is done, you ask your patient, how are you, Miss Anne? Are you okay? So Miss Anne said, I am fine. So this is what it is. So she is comfortable. So the procedure went well. So please make sure that everything is fine. So then you go for your replacement and your documentation. Documentation, first level, you will document. Somebody, your mic is on. So documentation also chronologically you go. First you do the assessment. What is no induration, no edema, no redness, no irritant by the patient. Then you will have to see. Then there is no bleeding. Sometimes you will find a fresh bleeding from your subcutaneous area. That is one more thing. And then, of course, you have removed it. Hydrogen peroxide was used. And then for cleaning, and the inner tube was replaced. See, there are many occasions there is a chance of forgetting the inner tube. Please make sure the inner tube is inserted and what time, what date it was done. So all this should be, and the patient is comfortable, especially the respiration is stable. That's very important. So this is what it is. And one more thing, if at all you do some suction, what kind of secretion? Was it thick secretion? How was it frothy secretion? So that also must be one of your observations during the documentation. So that way you can complete with the documentation. Thank you very much. Anybody has any question?
Good afternoon, ma'am.
Good afternoon.
Ma'am, how much of the air we have to induce into this tracheostomy? We are inflating the balloon. So how much we have to inflate?
It's hardly 3 ml air I have inserted. That is the balloon was full.
Okay. So whenever we are giving the air,
just 3 ml, 2.5 ml itself the balloon is full. That's good enough.
okay.
And
Ma'am, once again, ma'am, like whenever we are being
excuse me. And moreover, it depends on your tracheostomy tube size. If the tracheostomy tube size is bigger, then your inflating bulb will be smaller. So that again changes according to the size of the tracheostomy tube. Is that clear?
okay.
You got your answer?
Yes, ma'am. Ma'am, yeah, ma'am. Ma'am, one more thing. whenever we are cleaning the tube, do we need to deflate any time, because continuous pressure on that muscle may cause some damage to the trachea and all? Do we need to deflate or inflate any time?
Okay, good question. See, I'm telling you, anything to do with your outer tube, you leave it to the clinician. You consider this exactly like an endotracheal tube. See, when a patient's endotracheal tube is sitting in the trachea, of course, it goes through your nasopharynx and then the trachea. Understood? Yes, it's directly going there. The tracheostomy, see, I want to show you. See, tracheostomy, we make it very simple. I don't know how many of you would have seen a tracheostomy. How many of you would have seen a tracheostomy set? It's a big procedure. It's a big procedure. I have seen so many tracheostomy in my life. So we have a lot of stuff here. Tracheostomy, see, this is the tracheostomy set. So we have, of course, we make a nick with the knife, and then we have, see, and that too, it's not an ordinary, see, it is more than, it is almost 22 blade, you'll have to make a nick. Then, of course, you have tracheostomy hook. Tracheostomy, you have retractors, you have right angle retractors, and of course, then of course you do cleaning. So mosquitoes, you see that it's not an ordinary procedure. That's what I kept it here. You have two alleys because some of the tissues are very tough. So this is to control the bleeding, and there are two knife handles. You have one mesoform scissors, and this is called the tracheal dilator because trachea is made up of a cartilage. So it's not an ordinary tissue. Once you leave it, it goes back. Trachea is a corrugated tube. Once you leave it, it goes back. So you have to hold it with your tracheal dilator. Then, of course, your tracheostomy tube is placed in. So this much is it. And one more thing, I'm sure I want somebody to answer. When you do a tracheostomy, what is that you are very much worried in that area? So I have shown you the thyroid gland is one aspect which a surgeon will be very careful, and we have two carotid artery, right and left, going either side. So it's a very, bleeding is very high, that area. It's not very simple. So what why I'm showing you all this? When you think of the outer tube and inflating bulb, all should go to the clinician, surgeon. Any questions, for example, the intercostal drainage tube is coming out. You don't do anything. You just wear a sterile glove, take quite a big sterile pad, press it over the chest and call the clinician. We have our own limitations. Have I answered your question? Hello?
Yes, ma'am. Thank you.
Yes. So let us see,
we
like, where you, yeah.
Ma'am, we have some questions on the chat box.
Okay.
What is the most serious complication of tracheostomy?
What is it?
What is the most
After
serious
the
complication of tracheostomy?
Taking care of the patient, or I don't know. What is that they want to? No, while taking care of the patient, they are asking, or what is it? Which stage? You want to know the complication. See, when the patient tube is there, when I am giving care for my patient, the complications are bleeding, on-site ostomy, care time, bleeding. That's what I said. Cutaneous area, there can be air embolism, there can be fluid collection there, and there can be swelling there. I said immediate sudden, see, anything head and neck bleeding is very high, any situation. Bleeding can happen. So this is all where I care for the patient. I said assessment. So another thing is the tracheostomy itself, the inner tube is blocked. Inner tube is blocked. Your patient will be choked. Patient will, so immediately again you need to say maybe some kind of heart, the secretion which is blocking the airway. So it has to be, you have to bring a better suction and suction catheter. It has to be, again, clinician should be there to suck out. Otherwise your patient will be choking. and he will be, difficulty in breathing, all that. So is that what you understand? And during the surgery procedure time, I told you, thyroid is one concern, both the carotid arteries are other concern. And of course, the area is such an area where bleeding is always so much expected, which I have seen, so I am able to explain it to you better way. Have I answered your question? Whoever has asked this question?
Ma'am, one more question. How long we have to soak the inner cannula in the hydrogen peroxide?
How long? No, you don't need to soak at all. You don't need to soak for a long time. You can just, for a minute or two is enough, because that's what we make a mistake. The soaking, the hydrogen peroxide, the oxygen in that place will go away within a minute or two. So if you are going to soak more than that, it is of no use. That's all we are thinking. Soak for 1 minute, 10 minutes, nothing. The oxygen content in that hydrogen peroxide will go away in a minute or two. So quickly, that is why you need to use that brush. You need to brush. You need to use a brush quickly when you put. See, for example, I'll tell you, if your over is listening, if I have a deep wound, maybe full of pus, you take a syringe, hydrogen peroxide, you just push it in, and you find froth coming out. The reason is the oxygen goes in, and this oxygenation takes place, makes a lot of froth. The froth is bringing the inner dirt outside. That's all the purpose. Same applies here also. The oxygen is only 1 minute, not more. Quickly you have to soak it. Quickly you'll have to take it out. So there's no need of anymore, because there's no use of that. Oxygen will evaporate and go. That's why nowadays we are recommending only 100 ml hydrogen peroxide, not 500. By the time the 500 ml finishes, we are making a big mistake, because it is of no use. So that's why I usually recommend only 50 ml or 100 ml bottle. Hope I have answered that question.
Yes, ma'am. Ma'am, is it like diluted in anything, or it is like pure one, which is what we are going to use it?
What? No, your question
Hydrogen peroxide. Yeah, hydrogen peroxide, which we are using, is it a pure one from the bottle we'll be using, or in a dilution form we are going to use them?
It is better you see directly using, it is irritant. See, if it is on a skin, it is no problem. You have seen on the skin, it creates a kind of white patch, at least for 2 hours. So because you are going to put it on of course, tracheas, there's no mucous membrane there, not like your esophagus, but still it is a soft tissue. So it can irritate, because you won't know how much it is irritating, because it's not visible. So it's always you go for a minimum dial. See, your purpose of using this, the inner tube, the secretion, which is hard secretion sitting there, to come out. That is all the purpose. Once it is visible, your inner tube is clear, you are done. To make it as diluted as possible. There's no percentage fixed here. Make it as diluted as possible. Any other question? Good. Yeah. I'm very happy. Anybody from other Australia?
Any further question from anyone? Keep yourself mute, please, if you don't have any question.
Anybody has any question? I'm very happy. Many of you have asked questions. Is that all?
Ma'am, one more question.
Yeah.
Because we are using in the cannula, like in the campus, that is plastic one. So will it not have any other effects on that because of this hydrogen peroxide?
You mean this your inner tube?
Yeah, in the tube which we are using, because of this hydrogen peroxide on plastic, will it not cause any effects?
And that is what I'm telling you. You are not going to soak it for more than a minute or so. You are just allowing it to go through that tube, and you are just allowing it to go through. Allowing it to go through. You are just you are immersing it in a container. You are allowing the entire thing to go through, and then if you are using a brush, you are using
Yes.
a brush, and you are going to again take it out. See, hydrogen peroxide, it doesn't even harm our skin. That mild it is. And again, where we use our hydrogen peroxide, it's a concentrated hydrogen peroxide. So here we are doing it very much diluted, so nothing will happen to you. That I can 100% take. Nothing will happen.
Okay.
See, I'll tell you the soaking concept all happened, where we had a bronze or silver endotracheal tube, tracheostomy tube. I'm sure you all would not have seen that. We had a period silver tracheostomy tubes. We had bronze tracheostomy tubes. They were all metal tubes. So cleaning was very difficult. And this is actually very transparent. You can see anything sitting there. So we are lucky to have all these tubes, and these tubes can take up a lot of things. Nothing will happen.
ऑनलाइन क्लास चल रहा है
Thank you, ma'am.
Thank you very much. Good questions.
Thank you, ma'am.
How
Rohini.
much?
Ma'am, a question is there in the chat box.
थैंक यू मैम
If tracheostomy tube coming out accidentally, then what to do?
Which tube? Inner tube or outer tube? See, inner
Mr.
tube
Sawant, you
coming
want to
out
ask
is
the
our
question?
responsibility. Nothing to worry. You know that you just have to take it. Of course, you have to clean it again before you insert. That's all it is. Outer tube, there is no chance of, if at all it's coming, because there is a 2 suture put there. 2 massive suture, very strong suture, because there is a, that is why there is a hole here. So if you see that, so the suture is, there is a hole here. I'm sure you can make it out. So the sutures are put here. So that is anchoring this to your skin. So if at all one side it is done, that is what I'm telling you. When you put the thread, you will, this I want you all to learn very much. One thread only you will remove, and then you will put the thread again, and then only you will remove the other, then put the thread. By the time you will tie it at the back. So when you are going to be so careful, I don't think, I have not seen any tracheostomy tube, the outer tube coming out. It has never happened. Of course, if you think that way, you cannot just insert the same tube, because this tube would have been already unsterile. And see, one thing I tell you, for example, I'm sure you all know TURP, transurethral resection of prostate. When there is a benign prostate hypertrophy, when the prostate gland has been enlarged, the urinary, for men, the urinary tract is blocked. So then they will do a removal of bit and bit of either side when it is benign. Then the way is cleared. So that is what, then we put a 14 catheter, 14 size Foley's catheter, and it will stay for 3 days, and irrigations, all that you all know. So by chance, sometime the balloon got damaged. So the catheter will come out. So actually, according to curriculum, especially nursing curriculum, the male urinary catheterization is not our responsibility. We are not supposed to do male urinary catheterization. So it is strictly not told not to do. Indian Nursing Council don't approve of a nurse doing a urinary, because there's a lot of injury done to the urethra. But for a patient post TURP, I have done it. When a patient catheter comes out, it has to be put immediately, because there is irrigation, bladder will get filled very fast. So quickly you can put the catheter in. That's not a problem. I have done it. So we can easily, because the urethra is being So freely it is there and it can pass it. So what I'm trying to tell, if at all the inner outer tube comes out, you just have to take a sterile gauze, just place it on the ostomy area, make it a sterile gauze, you can call for a clinician. Because why I'm telling, the hole which is made in the trachea will not close so easily. If that, especially when the patient is going to be 1 month tracheostomy. That's why I'm giving the example as a TURP, post TURP. So you can quickly call, they will come and insert another. They will insert another tube, but you can't insert. I don't think we are supposed to insert. That's very wrong. We are not qualified to insert a outer tube.
Ma'am, may I interfere?
Have I answered your question?
Madam Rohini,
Yeah.
Brigadier Usha, ma'am.
Tell me, Brigadier Usha, tell me.
We were taught when if at all, it is a very rare chance, as you said, if it comes out, you are supposed to take the tracheal dilator and put it and keep it open till the clinician comes.
Okay.
If it is available. But nowadays, I don't know whether they keep all those sterile things while doing the dressing.
Nowhere the literature. I am not that way. My only thing, if the patient is going to be tracheostomy, that's why I gave the TURP as an example. The hole doesn't close that easily. So there will be a passage. But all till he comes, if there's going to be a patient choking, you can always bring a tracheal dilator and you can keep it open. No problem. No problem. If you find the patient is choking, not able to breathe, if that kind of crisis before they come, you can always keep a tracheal dilator and you can keep it open. No problem. If you don't get a tracheal dilator, you just take an artery forceps and just open and keep. Any instrument, you can just leave it open. You don't need to look for a tracheal dilator. What is even a dissecting forceps, you can just leave it open so that you have to.
Thank you so much, ma'am. Wonderfully presented as usual. Very clear, very simple, very nicely presented, ma'am. Thank you so much.
Thank you, Brigadier Usha. Thanks. वो हिंदी में समझ गया सबको और कुछ बताना?
किसी के कोई क्वेश्चंस हैं? If you have any questions, please.
हिंदी में पूछ सकता है. Okay.
स्टार भी दे दिया. मैम.
Yes.
Thank you so much, ma'am. I think so all are clear. Everybody is saying thanks on the chat, and that's a wonderful presentation and session, ma'am, as usual. Thank you so much for such an insightful session. I hope our all the nursing students and everyone would have been able to understand this. Someone is now asking, ma'am, please आप एक बार हिंदी में बता दो प्रोसीजर. मैम एक शॉर्ट में अगर आप हिंदी में छोटा सा बता सकते हैं क्या?
So I won't be able to. वो सब पता है कि अभी कैसा कर सकता है, but
मैम बहुत शॉर्ट में 2 लाइनर्स में अगर आप कुछ टिप्स देना चाहें तो वो हिंदी हमारे जो स्टूडेंट्स हैं उनके लिए
मैं एक्सप्लेन करूंगी. देखो ये प्रोसीजर बिल्कुल स्टेराइल नहीं है. बिल्कुल स्टेराइल करना बोल नहीं सकता है बिकॉज ना हम ये सब प्लेस वो सब अनस्टेराइल है. फिर भी हम हाथ धो के स्टेराइल ग्लव्स पहन के इधर थोड़ा एक स्टेराइल शीट लगा के हम ये शुरू करना. इसके पहले इधर सब सामान तैयार रखने में इधर एक किडनी ट्रे रखेगा, गालीपॉट एक किडनी ट्रे में हाइड्रोजन पेरोक्साइड डाइल्यूट करना. फिर कंसंट्रेशन मत डालना, ट्रकिया में इरिटेट हो जाएगा. फिर सलाइन आप क्लीन करने के बाद तो पूछा कितना वो सोक करने में, मैं बोलेगा 1 मिनट बस। सोक करके वो क्लीनिंग करने टाइम में देखो ये पगले बताना भाई। ये अंदर है, ये डालने में ये रखिया हम इनर ट्यूब ऐसा लेके ये ऐसा ये इनर ट्यूब हम क्लीन करने के बाद पगले ये इनर ट्यूब ये डायरेक्शन में ऐसा निकालना, निके ये उधर ही है। ये किडनी ट्रे में डाल के डाइल्यूटेड हाइड्रोजन पेरोक्साइड में 1 मिनट बस थोड़ा सा ये ब्रश डाल के इधर से क्लीन करना। ऐसा ही ट्राई मत करना, ये डैमेज हो जाएगा। ये क्लीन करके फिर इधर क्या हम पगले असेस करना, ये बहुत इंपॉर्टेंट है। असेसमेंट आपका मालूम है कैसा, वो इधर थोड़ा रेडनेस है, स्वेलिंग है, फ्रेश ब्लीडिंग हो जाए है तो वो भी देखना, ये सब हमारा रिस्पॉन्सिबिलिटी है। फिर एवरी 8 आवर्स के वंस हम ये केयर देना। फिर भी ये इंसर्ट करने में टाइम में ऐसा ही देखो ये पगले ये अंदर है ये ट्यूब, ये निकालने में भी ऐसा निकाल के ये क्लीन करके ऐसा ही डालना। ये डालने में बहुत इंपॉर्टेंस देना। फिर और एक है आपका मालूम होना, ये ट्यूब अंदर है ना, ये एंकर करने में ये एक 3 ml एयर, फिर बिल्कुल एयर ऐसा इन्फ्लेट करने में ये बल्ब सब।
मैडम प्लीज इंग्लिश और मलयालम हिंदी माफी मालूम है।
ये बल्ब होता है। ये कितना एयर फिल करने में ये साइज के बारे में वो डिसाइड कर सकता है। ये हमारा काम नहीं है, ये बिल्कुल डॉक्टर्स के काम है। यही मैं बोला था, ये थोड़ा ये बाहर आएगा तो क्या करेगा, मैं क्या बोलना, ये थोड़ा 1 महीना में ये अंदर है तो ट्रकिया में बिल्कुल क्लोज नहीं हो जाएगा। फिर डॉक्टर को बुलाएगा, डॉक्टर को बताएगा।
ये Redmi 9 अपना स्क्रीन शेयर प्लीज बंद कर दीजिए।
ये नेक टाइप दोनों निकाल के दोनों डालने की ट्राई मत करना, वो डेंजरस है। ये एंकर जरूर होना, एक साइड में निकाल के एक साइड में बांध के फर्स्ट छोड़ना, फिर दूसरा साइड के निकाल के दूसरा साइड में बांध के फिर। ये बहुत इंपॉर्टेंट है, व्हाटएवर जो कुछ आप बात के ये ऐसा मत करना, ये गलत है। सो दिस इज वन मोर थिंग। होप दैट्स ऑल।
थैंक यू सो मच मैम, हमारी स्पेशल
समझ गया
से हिंदी में भी लेने के लिए थैंक यू सो वेरी मच।
क्वेश्चन पूछो, कुछ
किसी के कोई सवाल है?
पूछने के लिए सवाल है, yes.
किसी के कोई सवाल है? किसी के कोई सवाल प्लीज पूछ लीजिए। मैम किसी के सवाल नहीं है, आई थिंक सो all is clear. Thank you so much for this insightful session, ma'am. As always, आपके सेशंस इतने अच्छे होते हैं कि everybody gets stuck to the screen and see the whole presentation and your demo. Thank you so very much for this insightful session, ma'am.
Thank you, Dr. Megha. I should thank HSSC for organizing and all the preparations you have supported us with. Thank you very much. Thanks a lot. Thank you for all of you who have joined. I'm sure something you have learned from today's session. Thank you very much.
Thank you.
With me, Mr. Srinivas, Ms. Cleope, and Gayatri, they all helped me in the lab. This is our fundamental lab and our mannequin. Thank you. Thank you very much.
Thank you so very much, ma'am. Thank you all of you. अब हम we will meet next month with a new session, with a new speaker, with a new topic. Till then, thank you so very much. We will see you next month. Thank you.